To the Thriving in the NHS Monthly Huddle. I'm your host, Ibi Funke. Today, we're going to be talking about quality improvement activity in the NHS. I'll just talk you through why we're doing this as I share my slides and go through the presentation. When I came to the UK, I was quite keen because during my interview, they had asked me if I had done any quality improvement activity, and I had said no because I hadn't. And I was like, oh, I'm very keen to learn and things like that. So they were like, okay, fine. So as soon as I joined, I was like, okay, I want to do quality improvement activities, and I would talk to people. And it wasn't really clear that, I couldn't join any teams, I couldn't join any ongoing audits. So it was difficult. And then just before I left that unit, someone had said to me that there was an opportunity to present a quality improvement project that another doctor had started. And did I want to take up the opportunity? And I did. Through that opportunity, I engaged with the Quality Improvement Hub. I was very lucky in that first hospital. The Quality Improvement Hub was an office that was accessible to doctors, and they would help you with your data collection, they would help you with your data analysis and things. So that way, I learned a lot. And then from volunteering to complete the presentation of this audit, I then got the opportunity to learn even more because it was a quality improvement day organized for trainees, and there was lots of teaching. So it was a really, really good opportunity for me. And I learned a lot. So some of that learning I've carried along with me as I've gone through different jobs in different trusts. And I thought it would be helpful for people to have that knowledge as they navigate their careers. When you do your job applications, when you're applying for training, when you do your interviews, you always get asked about audits, because when you have participated in an audit, it demonstrates to the team that you're keen, you're interested, you care about the outcomes for your patients and things like that. So once you're able to communicate on that level, it does well for you. So we'll be talking about how to select a project for your audit, how to get involved, registering it, data collection and analysis, some tips, and then we'll talk about what to do with your results and how to make the most of things. So NHS England defines clinical audits as a way to find out if the healthcare being provided is in line with standards, and lets the providers and patients know where the service is doing well and where there could be improvements. So how do you select a project? How do you get involved with an audit? So if you work in a unit, you might get times when like people will be like, oh, there's this great audit that you could do. And then you hear the thing and you're like, I really don't want to spend time doing that. Or sometimes you listen and you're like, oh, actually, that's something that aligns well with my goals. How you have to consider your schedule. How easy will it be to participate in this project? And then think about what the team is interested in. So after I had the first exposure by finishing off a project that someone else had started and learning from that quality improvement day, I then went to the team and I said, oh, is there any project that you would like us to do? And then someone told me what they wanted to audit. And that's useful because it saves you the time of coming up with topics that no one in department really cares about. And then you can look at the data collection and you can think about what are the prospects for this. And when I say prospects, I mean things like, can you get this published as a poster, as a paper? What is the value of the data to you beyond this presentation? And then you think about your personal goals as well. So the purpose of the clinical audit is clear. That's to improve quality. So you assess the quality of what you're doing, and then you improve the outcomes for your patients if there's something to be improved. Okay? What outcomes are desired for you? So say, for example, you have a short time and you have to participate in as many audits as possible, then you don't want one where the data collection is going to span 6 months. You have to think about something that will be, the turnaround would be quick for you. How much effort is required? So how many hours are you going to have to spend using to collect data, to analyze data, to chase people and things like that? What are the opportunities to publish or do something with this? We've talked about that already. And within your professional team, how much support can you get? Is this something that the consultants are going to be willing to back you up with, or is this something that you're going to have to be like, it's not relevant? So you have to think about those things as well. So when people talk about audits, they will talk about standards, and that's something that's very useful to understand, because that forms the baseline of what you're doing. How do you find what is a standard? So the standard is what has been dictated or what has been published as acceptable. So, for example, the standard of care for women who have complaints about their breasts is if they're over 40, they get a mammogram, right? And that can be found published in, say, NICE guidelines, in literature, things like that. What's the basis of the question that you want to answer? So that's where you have to go into research and see what has been done in that area before. And then how do you choose the area you're going to focus on? Because it has to be something that is relevant to improving quality to patients, and it has to be something that you can actually improve if you find that things are not going the right direction. And then you have to design your data collection so that it can demonstrate that either your unit is working along with those guidelines or has deviated from the guidelines. When you register, when you have an idea for an audit, whether you've discussed this with your consultants or discussed this with the team, you have to think about registering the audit. And the reason this is important is sometimes people can be cheeky. You discuss your projects with people and someone else may go and register it before you get the chance to. Other reasons for doing this are so that you can get the evidence to say that you've actually done this audit, and you can use that evidence for, say, training applications or CSER applications or things like that. And then you need to think about the data that you require. So sometimes we try to go at this the hard way, where we're scrumming through patient notes, but sometimes you can actually get the information easily enough from clinical coding team, the quality improvement team. So think about where you can get support. So for example, I was doing an audit on patients who had been treated for breast cancer. And one of the things I did was I went to the, breast cancer care coordinators, and I kept asking questions until I found someone who could give me the data set I needed without me having to go through the forms. Okay, so that's how, as far as registering your audit goes, it's very important. A lot of the time we take it for granted, but it's really important, especially for evidence collection. As a minimum, when you're collecting data, so I would recommend that you use Microsoft Excel if you're collecting the data yourself, rather than using Microsoft Word, because I've seen people use Microsoft Word for these sorts of audits, and it doesn't really help you because it doesn't give you the tools to manipulate the tables and get the results that you need. And I'll talk about some of that in data analysis. Make sure that your data collection is focused on the question that you're trying to answer. So sometimes we get into these audits where someone is like, oh, let's just ask this and ask that, and then at the end of the day, we'll find something. Be very wary of doing that, because you just create a large data set and then you can't really make sense out of it or get results out of it. So make sure that your data collection is answering the specific question that you're trying to answer. Have the minimum data set so that you can find this person again if there are any doubts as you're analyzing the results. If it's possible to get all your data electronically rather than going through patient notes, then you should absolutely do that, because it will make your life easier again. If there's any support available from your audit department, then take it. Sometimes they'll help you with data analysis. Sometimes they'll help you with things like generating graphs. Sometimes they'll help you with things like designing or printing posters. So whatever help that is available, you should definitely find it and use it. When you're thinking about the audit, if you're leading, then you need to think about who you invite to join you in this audit. You need people who are committed, so also have goals that they're trying to achieve with this audit. You need people that you get on well with. At the outset, you should determine what the rules are. So if you're leading, then that means if any publication comes out of this, then you'd be first author, things like that. Talk about it, agree beforehand to reduce the likelihood of any friction down the line. And then set SMART goals. So be specific about the amount of time you want to spend on data collection, the amount of time you want to spend on data analysis. Let them be time bound so that you have the period of time over which you're going to carry out this audit and stop and complete it, present it as much as possible. I'm describing the ideal situation. Sometimes things will fall away from your plan, but at least when you have a plan, you can kind of see where things are not going the right way. And then try to monitor your progress regularly. Okay. See how you're getting on. Have someone who's holding you accountable to say, okay, what are you doing next? Where are we going next with this? If you get the opportunity, sometimes before you do an audit, you can present it to the departments and say, this is what we're planning to audit. This is the data we're going to collect. This is what we're hoping to find. And you can discuss that and people can give feedback, and then that gives you the opportunity to fine tune what you do. It's not always possible, but when it is, you can take advantage of the opportunity. If you're going to audit, if you're going to collect data as a team, then it needs to be done in such a way that each person can collect their data. Data can be merged in the end. It's centrally accessible. So there are drives in most hospital computers that are accessible. You can have like a drive that has a password, so only the team members can use it or things like that. But just make sure it's centrally available and accessible to everybody, and you can all put the data together. It emerges nicely at the end, and you don't have to analyze the data in silos. When you're collecting the data, as much as you can for the questions, especially for the sorts of questions that are in response to the audit standard, there are these things called drop-down lists on Excel. So what you do is you go to data validation. This you can Google search at the end, just creating drop-down lists on Excel. And what that does for you, it gives you the opportunity to say things like yes or no, or 1 and 2. And then when you're analyzing the data in the end, you filter. So for when you want to see how many people it was yes for, you filter out no. And then you can just count the number of people it was yes for. And that makes life so much easier than having to read text, especially when people have entered the text differently. So let's say one person says, had a mammogram, one person says, did have mammogram, one person says, did not have mammogram. So you have to read the text and decipher what everybody's trying to say. But if you have that drop-down list, then you can just easily pick what you're doing. Okay. So we've talked about data collection and the timelines and working with teammates you like. So this slide is an example of minimal data set. And for Instagram crew, I'll just talk about what's on the slide. So you have an Excel sheet diagram, and you've got the NHS number of the patient, the name of the patient, their date of birth, their age. And then this one, the standard we're looking at as an example is 100% of women over 40 who present to the breast clinic should get a mammogram. So your question then becomes, what proportion of women over 40 who came to the unit had a mammogram? So to that end, this data collection tool that we've described gives us the mammogram would be yes or no. And then when you come to before we get to the analysis using that example, I'll just talk about some of the data laws because it's very important. You need to get permission from your governance team if you're going to collect any patient identifiable data. Some trusts, depending on the extent of data you're collecting, you may need to go with the Caldecott. You may need to make sure that you've kept in line with all the Caldecott principles. There are 8 of them. You can look them up and find out from your trust how this applies. And you should not transfer any patient details to personal drives. So if you're going to use a personal computer, then make sure it stays on the electronic drive of your hospital rather than on your personal system. Now, coming to the results, how do you analyze your data and how do you present it? So the age of the patients, their gender distribution as applicable. So in our case, this is mammograms. and we're talking about women over 50, so that means you've got only one gender. But if you do the age, then you should give an age range of the patients that you've seen. And then you then look at the performance of your unit against the standard. So remember, the standard was 100% of women over 40 get their mammograms done. You then look at what was the gap between your unit and the standard. And then if your unit fell short of the standard by a significant amount, then you've identified an area that you can do some quality improvements activity on. You should, for every audit you do, at the barest minimum, you should get a local presentation out of it. But you should also, if it's something you desire, aim for oral and poster presentations in national and international conferences. That's, of course, if it's something that you want and if it's relevant to your goals. But at the very least, you should have a local presentation, because if you don't present the outcomes from your audit, it means that no one is aware, especially if you're falling short of the standards, that there's room to improve the quality of what you're doing. And you can make recommendations based on your audit and what you found the reasons for falling short were. So here I'll talk about an example of two different result sets for the people for the same question that we asked earlier. So if you look at this unit, they had 158 female patients over a 6-month period, and this was what the data that was audited. The women had their ages ranging between 40 and 95. So results in one set of results, this is assumed results, 98% of patients had their mammograms done. So in this case, it's clear that there's no real room to improve quality. If you look at the reasons, say, for example, one of the women passed out before her mammogram, and that's why you had 98% instead of 100%. So the unit is doing fine. There's nothing to improve. In another different scenario, only 49% of the patients had their mammograms done. You can clearly see that there needs to be something done about this, because it's falling really, really far off the standard. So this is then where you share the reasons with the team, what you found, why these mammograms were not done. You make recommendations, and then if you'd like to carry on to quality improvement projects, you can then re-audit that after a period of introducing changes and see how that has impacted the performance of your unit. And we'll come to quality improvement projects at the end. So for data analysis, we talked briefly about this earlier. So you see, there's at the top, I've put circles around it. So where the area that you'll be working for your data analysis would be in the data tab on the Microsoft Excel. And then you'll see, once you've done the data tab, you'll then see filter. So when you click on the filter, because you've already done this drop-down menu, you can then pick on the drop-down menu and edit out the things that you don't want to see. So if, say, for example, mammograms, you don't want to see the ones who didn't have a mammogram, and then you just look at the ones who had a mammogram. You filter out no, and then you count, you look at the age range, you look at those results and things like that. Okay, so this is an example of an audit. So now I've talked about using Excel, and that's for a local audit where you're designing the data collection and things like that. Sometimes you might be involved in a national or a global audit, in which case the data is entered onto a database and then you get the results down the line. So for those who want to be involved in national audits, those ones give you a higher chance of getting your projects published in, like posters published in conferences and things. So you take that report from a previous year, you look at it, you look at areas where you feel like your trust or your hospital is not performing well, and then you approach someone and say, oh, look, I want to work on this, we're not doing well, I need support. And they say, yes, fine, go ahead. So that was what I did with this audit. I looked at an annual report. I saw that we were not doing well. I approached the consultant, and then we started the quality improvement project, because this served as the first audit. So I didn't have to audit anything. I just went off the back of the previous year's report and then came back and implemented changes, and then we audited that down the line. So this was the database, the NILA database. It's a national audit. So you'd go in here and enter details about your patients. And at the end of 3 months, you'd get a publication, your quarterly report for that hospital. So after doing that project actively, you can see how we moved from a lot of orange to a lot of green. And then over time, we then dropped again. So we could see that we needed to do more to sustain the greens in what we were doing. And I was able to present that. We were able to work on a laparotomy pathway and things like that. At this point, I'll talk about the Pareto principle, which I believe very strongly in, especially for audit and efforts. Pareto principle states that you use 20% of efforts to achieve 80% of your outcomes. And what that has meant for me with the audits is, for every audit I've been involved in, I've made sure that I've maximized the output from it. So one audit was presented as a poster in the Association of Breast Surgery. It was also published in a journal that is indexed on PubMed. I wasn't the first author, but I still put in my work and I got these publications out of it. A different audit was published as a poster in Association of Surgeons in Training conference. And that abstract, not a paper, the abstract was published in the British Journal of Surgery. And I went on to do the same thing. One audit published in the European Society of Surgical Oncology, and the abstract published in the European Journal of Surgical Oncology. So it's important to maximize your outputs from what you're doing as much as you can, especially if you're considering training, because sometimes training it's kind of a tally system. So you've done this tick, you've done this tick, and then the marks add up to take you where you want to go. So opportunities, because people will sometimes ask, like, how do I get involved? How do I get involved? Sometimes you don't have to start an audit from scratch. There are audits that are being run nationally by trainee-led groups. So the surgical ones, you have things like ROLU for vascular surgery, you have things like Duke's Club for colorectal surgery, and so on and so forth. So all the sort of consultant groups have their trainee-led groups. Mammary Fold for breast. I'm sorry, all my examples are very surgically inspired, but all these groups exist for all the specialties. So find your trainee-led group, find out what audits are happening, see if you can enroll in the audit. And that's very low-hanging fruit. The national audits going on, I'll put up a slide to show you what those national audits are, and you can get involved. The global audits going on. So I use social media a lot to find out about what's happening, particularly Twitter or X, as the name is now. And you can find out things that are happening from there and get involved. So these are the Healthcare Quality Improvement Partnership is a place where you can find the national audits that are happening. And you can see that there's no specialty spared. There's epilepsy, there's gastrointestinal, falls, heart, like everybody's represented. There are national audits in all of these things. And what's good about this is you don't have to reinvent the wheel. You just go and see what the last published reports about your hospital says, pick out an area where you're not doing well, find a consultant to support you, and create your quality improvement around that, or audit of even why you're not doing well, and then create the quality improvement around that. Okay, global audits. Global Search is one I've been involved in, and the good thing about Global Search is they will publish in a well-ranked paper, and you'll get to be listed as an author for your participation in the audit. So if there are global collaboratives like that you can get involved in, that's fantastic. Kidney disease, improving global outcomes is one I came across when I was doing research for this as well. And that brings us to quality improvement projects. What are they? Quality improvement projects can be quite tricky because sometimes you get bogged down by all the things that are happening around it, and there's so much buzz around it. The model for improvement is the popular one that is used within the NHS. And what that is, or is this, literally. So you plan, you do, you study what you've done, and you act based on what you found. So, and the three questions we ask is, what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? Okay. And the thing about this is, so I've said aim, measures, and changes. And then when we come to the next slide, you will understand that a bit more. So you have your aim. Your aim, for example, so let's go back to the example we've been using. Aim is 48%, or we have a unit where only 48% of the women showing up are having their mammograms when they're aged over 40. And what we want is to move that to 100%. So your aim in this quality improvement would be for 100% of women over 40 to get their mammograms. And outcome measures would be the number of women that are aged over 40 that are having their mammograms. So you then design your primary drivers. So what are the things that you found in your audit that were preventing people from having mammograms? Can you change any of those things? What are some of the things that were also impacting? You put that in your secondary drivers. And then this is slightly hidden away. So changes is the last column, and changes are the small things you can do. So say if a woman is over 40, when she goes into the doctor's room to be seen, she has a sticker that says over 40 on her folder, so the doctor doesn't even have to think about her age. It's right there in front of them as soon as they see the patient. If the doctor has not requested a mammogram and the patient gets to the radiography departments for their mammogram without a request for a mammogram, it's flagged at that point to say this patient is over 40, a mammogram has not been requested. Why? So those are small changes you can make. So balancing measures are the things that you know will create pushback. So this process is going to be longer, it's a bit more complicated, it's more clunky, people may not like it, things like that. So those are the things that you put in the balancing measures. So I'll then share one example. So this is one I've done in the past, and it doesn't have the changes on, and you can see how it was, 100% of patients who have laparotomies will be risk assessed prior to surgery, will have appropriate level senior input and planned ITU admission if mortality risk is greater than 5%. Okay, and you can see in the middle the primary drivers, and you can see the secondary drivers. So in this one, I think, again, it's constant learning. Some of the secondary drivers are mixed with some of the changes that we were making. And we had balancing measures. We could see how everything was working out. And one of the things that was particularly interesting for me as I learned on this quality improvement project was, at first, I didn't have consultant level support, and I was literally doing all the work on this project. So all the things that all the SHO level people were meant to be doing, I was doing. And then something changed at the sort of national level, and people were scrutinizing this data more. And so I got more support, and all of a sudden, people were looking at all the data entries and identifying who was responsible for data entry, and it had to be done. And that completely changed the project and changed the outcomes of what we were able to accomplish. The PDSA cycle. So we talked about plan, do, study, act. So you do one thing, you see the impact that has had, then you do the next thing, you see the impact it has had, you do the next thing. And if things are not going sort of the way you would like, through the PDSA cycles, you can come back and say, okay, actually, let me see, what's this, what's that, what's this, what's that, that sort of thing. What can I tweak? What can I change? And you can move things around so that you can get the desired outcome you want, which is to see an improvement. And of course, at the end of this, you then audit. So you do the quality improvement project over a predetermined time, and then you go back and you audit. So what you audit is exactly the same thing that you did the first time. So how many women over 40 got their mammograms when they came to the department? And what will tell you if your quality improvement activity worked is if that number has gone from 48% to 88%. And that's what is called a completed audit cycle. And that's why if you're doing like a training application, a completed audit cycle is counted as two audits for you, because you've audited the first time, you've improved quality, or you've done a quality improvement activity, and then you've audited again to see how things are going. So that's the sort of the basics, introduction to clinical audit and then quality improvement activity. So I'll talk about myself, what I do now, and then we'll take questions. Instagram crew will be ending on Instagram after I've talked about this part of it. And if you'd like to join us for questions, you can still register with the link in my bio. So my name is Ibifunke Pigbaotemulu. I'm an ST4 in general surgery. I'm a wife, I'm a mom, I'm many things in between. And I run Thriving in the NHS, which is an effort to support international medical graduates who are based in the UK to make sure that you live a fulfilled life and you achieve the things that you came to the UK for. On Instagram, you can follow me at Ibifunke or follow Thriving in the NHS, and you will receive encouraging content to help you in your journey. This QR code is for our Linktree link, and this is where you can catch up with all the things that we do. Whether it's courses, the book, podcast, YouTube, whatever you're trying to find that's related to Thriving in the NHS, you'll find when you scan that QR code. So for Instagram crew, you'll find it in the link in my bio because the Linktree link is there. The monthly huddle, so that we're here. In the monthly huddle, we come together and I talk about my experiences, and at the end we take questions and we have discussions around what's going on in everyone's life and things that we can help each other with. Next month we're going to be talking about taking back your power, because one of the things I've found in working in the NHS and talking with other IMGs is almost everyone goes through this experience where you kind of lose a sense of direction. You're not sure what you want to do. You're not sure why you're here. So next month we'll be talking about taking back your power, using assertiveness and different skills that I've learned along the way. Link to register is also in my bio and will be in the QR code if you scanned it. Saturday, October 21st at 10:30 a.m. again. If you sign up to the newsletter, which again is in the link in my bio or in QR code, you'll get the newsletter once every month, also full of encouragements, sharing stories about myself, and hoping they lift you up. The Thriving in the NHS book is, hopefully you can see it in the background, that's where all of this started. Well, not really. It started from the blog and then it morphed into the book. And Thriving in the NHS was born 3 years ago now, and we've carried on supporting international medical graduates in the UK. Other resources for IMGs. So thankfully, I'm not the only one who does it. There are lots of people who are supporting IMGs in different ways. IMG Advisor has a group on Facebook that is full of thousands of people. Road to UK, Ibreeze and Mohammed, they have a YouTube page, Facebook page. They churn out lots of support for IMGs, especially with changes to like the PLAB exam and all sorts of things. So you should definitely look them up. They have lots of tips that they share. TrueLink, I follow on Instagram. They share helpful tips all the time. Healthy English is focused on communication for IMGs with an understanding that the sort of English that we speak is different from English and communication amongst locals. So just bridging that gap and making life easier for people. IMGs in the UK is a Facebook group, also has thousands of people who share all kinds of experience that you can learn from. And then there are country groups. A country like Nigeria, we have 2 groups. We have MANSAG, we have NDUK, there's the Ghanaian doctors in the UK, there's British Association of Pakistani Doctors, Indian Doctors, all kinds of groups. So find your people and get the support that you need, because we all need support. There's no denying it. As an IMG in the UK, you need support. Okay. If you'd like, if you're in that stage where you're struggling and trying to find direction, you can book a clarity call with me. This is the QR code to book it, and you can book a one-to-one session, and we'll organize a timing that suits both of us. We'll talk for an hour, and you'll gain clarity by the end of that hour about what actions you want to take, what steps you want to take, and how you're going to measure your progress.